For the critical thinking assignment, the case that comes to mind is a case from last week. It was a 15-year-old male with a history of scoliosis that was here for thoracoscopic vertebral body tethering. He was an otherwise healthy kid, and other than a questionable MH history in his family requiring TIVA, we didn't really have any health concerns. For the case, he did require one lung ventilation. So immediately for anticipating problems, he's at increased risk of hypoxia with the one lung deflated. When he got in there, the induction was well tolerated. SATs were good, and so the right lung was deflated for the surgery. At this time, we had decreased saturations despite increasing the FiO2, so SATs were maintained at 88 to 91, even with the patient on 100%. So we ran through the potential causes. So initially, we thought about troubleshooting equipment. So we looked at the SAT probe, and it was a good tracing. We couldn't actually access a SAT probe on him with the drapes, so that was kept in the back of our mind that maybe there was some sort of mechanical issue with the SAT probe. And our second thought was, did the tube move? So we brought the bronch back out and we checked the placement, and that was still in good place. And then we were considering physiological effects when the patient started to become symptomatic with the decreased SpO2. So his heart rate had dropped from the 70s down to the 50s. So this required early recognition of a changing situation. So once he's symptomatic from decreased saturations, we notified the surgeon and we reinflated the lung. At that time, SATs improved, and we did perform some recruitment maneuvers to see if the dependent lung had some atelectasis. The lung was then deflated again, and the surgery was started. And at this time, we decided to try to hook up an MIE and just have some oxygen flow going to the deflated lung to see if that would help. But saturations were still a little bit low. They're still sitting at 91 to 92. So at that time, from our evaluation skills, you could tell that the issue had been one lung ventilation, because he immediately improved with having both lungs inflated, and then decompensated again when we deflated the one lung. So then when we were thinking about maybe the possible physiological effects that could be causing this, one lung ventilation results in mixing of deoxygenated blood from the collapsed lung, and it mixes with the oxygenated blood from the dependent lung. So this would cause decreased SATs, but there is a compensation mechanism of pulmonary hypoxic vasoconstriction. So once we ruled out other problems like the atelectasis or mechanical issues, our thought was that we were waiting for this compensation to occur. So the low oxygen level surrounding the deflated lung results in pulmonary vasoconstriction to decrease mixing of the deoxygenated blood. I considered that it might just take some time for this compensation to occur, and the lower SATs might happen before the compensation occurred. So with this in mind, we turned off the MIE oxygen flow that was going, just in case this was prolonging this compensation mechanism. And within a few minutes, the patient's SATs had increased from 90% to 97% and stayed there for the rest of the surgery. So I think we may have got fixated on a lower SAT at the start. We reacted appropriately when his heart rate and he started to drop. He became symptomatic, but otherwise we were able to talk it out and figure out what might have been the problem causing it, and it was eventually fixed.